Okay.
Yeah, no problem.
Okay, so welcome everybody. So we're quite privileged today in that we have one of our participants, Dr. Trisha Paul, all the way out in India, who's actually going to be doing a presentation for us. And she's hoping to make a name for herself in the United States. And we wish her all the best of luck. So as part of that, she's doing these presentations and hopefully she'll do a few more with us. And today she's going to be talking to us about emergency department management of gastrointestinal bleeds, upper gastrointestinal bleeds, if I remember correctly.
Yeah.
Yeah. Okay. So I just want to welcome her, and she's been, I know she's been on one or two of our groups before. I mean, she's participated in a couple of our sessions before. So it's really nice to have one of you guys presenting as well. And I'm going to be quiet now and she's going to take over. All right. And then you'll hear us talking throughout the thing. Okay. So Trisha, this is going to be you as the host. So you do whatever you need now. I'm just sitting quietly and listening and participating as I need to.
Hey everyone, I'm Trisha, and today I'm going to be talking to you about the approach to GI bleeding in the ER. Now, I'm just going to share my screen really quick. And here you go. So, approach to GI bleeding. So, before we get into the management, I'd like to talk about the potential causes of GI bleed based on the location. So common upper GI bleed causes include duodenal ulcer, gastric ulcer, gastritis, esophagitis, varices, Mallory-Weiss tear, aortoenteric fistula, malignancy. And lower GI bleed causes include malignancy, diverticulosis, colitis, anorectal disease like hemorrhoids and fissures, angiodysplasia, and Meckel's diverticula. Now, your signs and symptoms of bleeding based on location. So almost always an upper GI bleed presents with hematemesis. Other symptoms include heartburn, epigastric pain, melena, syncope. And lower GI bleed can present with bright red blood per rectum, melena, diffuse lower abdominal pain, and anal fissures. Now, say you do have a patient with melena and you're not sure if it's an upper GI bleed or a lower GI bleed. One thing that can help you differentiate that is the patient's age. If your patient is less than 50, you can be sure that the cause is an upper GI bleed. Well, is it really necessary to differentiate the two in the ER? Actually, no, because the treatment is the same for both. Your patient is bleeding either way. So it's not really important, but it does help you narrow down your differential diagnosis. So what do you do when you have a patient that presents with a massive GI bleed? First, you have to take a thorough history. And in your history, make sure to ask your patient if they've had taking any anticoagulants, any antiplatelets like aspirin or NSAIDs. So this is important because we need to reverse that coagulopathy. And then alcohol history can guide you with your differential diagnosis. It's most commonly going to be a varicose bleeding in that case. Ask your patient if they've had any prior ulcers or bleeding, a recent colonoscopy, and a AAA repair. Why do we ask about the AAA repair? Because one of the complications of it is an aortoenteric fistula, which can cause a massive GI bleeding. And the management for that is different. You'll need a graft and bypass repair. So after history, the next you do is labs. So you cross and type blood, get CBC and chemistries to set a baseline. You check the PT, PTT, and fibrinogen again to see if your patient has any coagulopathy. After the labs, you check if your patient is stable or unstable. And you can do this by calculating the shock index, which is heart rate divided by the systolic blood pressure. If the shock index is more than 1, you will need to transfuse. If it's more than 1.4, you might have to start the massive transfusion protocol. And what the massive transfusion protocol is basically platelets, FFP, and fibrinogen, or packed red cells. Packed red cells, FFP, and platelets all given in the ratio of 1:1:1. And fluids. So for fluids, you will need 2 large IV access, or an IO access works as well. It's important to keep in mind to avoid excessive fluid resuscitation. The idea behind this is that your patient is losing blood, so you replace blood with blood. So aim for a mean arterial pressure of more than 60 millimeter mercury. Your transfusion, this is the most important step. You replace the patient's RBCs with packed red cells. So you can start with 4 units. If your patient is still unstable, give them another 4 units and think about starting a massive transfusion protocol. So if you have enough time, you can get group specific with the packed red cells. But if very less time, give your patient ONEG immediately. So guidelines recommend a target hemoglobin of 7 grams per deciliter. The only problem with that is that the labs are not gonna stabilize immediately. So instead, target for clinical signs of tissue perfusion and vital signs. That includes like urine output, pallor, blood pressure, capillary refill. And reverse any potential coagulopathy. So if your patient has liver disease, check their iron. Give them FFP if it is increased. And FFP basically contains clotting factors, fibrinogen, plasma proteins, protein CNS, all in the concentration, same as normal plasma. Now, if your patient's on warfarin, they will require prothrombin complex concentrate, which contains factors 9, 2, 10, 7, protein C and S. Now, we've all learned ABCs, that it's airway, breathing, and then circulation. This is one case where you have to stabilize the circulation first, which is why we did the transfusion first, and then you can come to your airway. And airway is going to be hard considering that your patient has hematemesis and they're going to be actively vomiting. So direct laryngoscopy might give you the best view. So there are a few things that you can do in order to decrease regurgitation and aspiration. That would be emptying your stomach before you intubate, either with an NG tube or a prokinetic agent like metoclopramide or erythromycin. Now, lower the induction dose of the anesthetic to avoid hypotension. Don't skimp on the paralytic to avoid vomiting with aspiration. Now, while you're intubating, if your patient does vomit, you can decontaminate the airway by placing the patient in a Trendelenburg position. And another thing you can consider is SALAD, which is suction-assisted laryngoscopy, airway decontamination. What this basically is normal laryngoscopy, except instead of using a tongue depressor, over here you use your suction to clear the airway at the same, whilst you're intubating all at the same time. Now in med school, we've learned about all these other interventions that you have to give your patient, like PPI, octreotide, tranexamic acid, and antibiotics. But the only one that is shown to decrease mortality, especially in patients with variceal bleeding, is antibiotics. So give your patient ceftriaxone 1 gram. PPIs can be given in peptic ulcer bleeds, but trials have shown that there is not much benefit to it before endoscopy. Octreotide can be given for variceal bleeding, but it wouldn't be the worst thing if you didn't give it to your patient either. And tranexamic acid used to be given for upper GI bleed, but recent trials have shown that there is absolutely no benefit nor any harm caused by giving tranexamic acid to your patient. So the only real treatment that can stop your patient from bleeding is endoscopy. All these other measures that we discussed are resus methods. And so call your GI specialist immediately and do the endoscopy as soon as possible. Now, say you've called a GI specialist, now they're late, and you've transfused multiple times, and your patient is still bleeding. There is one thing you can do in the ER in patients with variceal bleeds. It is balloon tamponade using a Blakemore tube. I do have a short video that shows on how you can do it. I'll play it for you quickly.
Here's the Blakemore tube in less than 5. Buckle up. There's 3 ports, one for blowing up the stomach balloon, one for the esophagus balloon, and one for suctioning the stomach. There are suction holes for the stomach, no suction holes for the esophagus, and 2 balloons, one for the stomach and one for the esophagus. You also need an OG tube, a 50 cc syringe, Kelly clamps with tape on the edges, 2 3-way stopcocks, 4 dual lure lock caps, lubricating jelly, a manometer, and I recommend the Posey cufflator because it fits onto the 3-way stopcock and it insufflates, and your respiratory therapist has one, just call RT. A Christmas tree, a Sharpie pen, a traction device, and we're going to use Curlix and a liter bag of saline, and a bucket of water. Insert 1 3-way stopcock in the gastric balloon port, and then you're going to take a second 3-way stopcock and insert it in the esophageal balloon port, and these should fit pretty snugly. Now take your OG tube and line it up so the tip is just above the gastric balloon. And at the 50 centimeter mark on the Blakemore tube, you're going to label the OG with a G. Now line it up so the tip of the OG tube is just above the esophagus balloon, and do the same thing. At the 50 centimeter mark on the Blakemore tube, you're going to label this with an E on your OG tube, and this will make sense in a minute, I promise. Now we're going to test to make sure our balloons don't leak. So take your 50 cc syringe, connect it to the esophagus balloon port, and we're going to dunk it in some water, inject some air, and make sure we don't see any bubbles coming up. Once that looks good, we're going to deflate it and we're going to test the gastric balloon. We're going to use the same sophisticated technology for testing the gastric balloon. So stay with me on this one, and I think you'll get it. Dunk it in some water, inject some air, and check for air bubbles. All right, moving on. Deflate that balloon all the way. And now we're going to get ready to insert this thing. Get some water-based lubrication, lubricate the tube and balloons, and insert it just like an OG tube. Technically, you can go through the nose, but I think the mouth is easier. Insert it all the way. And now we want to test to make sure that it is in the stomach, not the esophagus. So inject 50 cc's of air and get an x-ray. Make sure the air bubble is below the diaphragm, and now it's safe to continue. The Blakemore tube holds 250 cc's of air. 250 cc's, that's 4 more pushes from your 50 cc syringe. Now turn it off and you can place 2 caps on your stopcock. And now we're going to set up traction. So we are going to use our liter bag of saline and our Curlix. You're just going to tie a basic or run-of-the-mill slip knot around your Blakemore tube on this end. And with the free ends, you're going to grab your liter bag of saline and just push those free ends through the hole on the top of the bag. And you can just tie a regular run-of-the-mill knot here as well. Now you can hang this up over an IV pole. And this pulls 1 kilogram of traction. No football helmet required. Now we're going to connect suction to the gastric port and suction out all of the contents of the stomach. And now you're going to insert the OG tube so that the G that we marked on the OG tube lines up with the 50 centimeter mark on the Blakemore. Now we know the tip of the OG is just above the stomach balloon. Now clamp the gastric suction port and move the suction tube from the gastric aspiration to the OG tube. We're going to check to see if we have residual bleeding in the esophagus. If there's still lots of blood, that means we need to inflate the esophagus balloon. So pull the OG back till the E lines up with the 50, and now the tip of the OG tube is just above where the esophageal balloon will be. Grab your cufflator manometer, and we are going to connect this to the 3-way stopcock on the esophageal balloon port. Place another cap on the 3-way stopcock and grab your manometer. Remember, inflating the esophagus balloon is all about pressure, not volume. So connect the manometer here, and when you squeeze the bottom of the cufflator, it inflates air into the esophagus. The goal is 30 millimeters of mercury. You can go up to 45 if you're not getting adequate tamponade. Once you're at 30, close the stopcock so it's turned to off. Remove the manometer, and you can place a cap on this remaining open port. And that's the Blakemore in under 5.
Yeah, they make it look easy, but going back to presentation. So the final key points that I want you to take away from this entire presentation is transfusion. That's the one thing that can help your patient, and transfuse before you intubate. Don't forget antibiotics, if your patient does have a varicose bleed. And keep an eye out for the patient's INR and correct that coagulopathy. And thank you so much for listening, guys. It's been a pleasure. And oops.
But yeah, the thing that you were saying, about the history was extremely important. That's one of the things that we often miss. And one of the things that I just wanted to add that, you also need to take in consideration patients with hemophilia. Very often they're quite predisposed to all of these conditions as well. And it just adds a little layer to what you need to treat them with. You did speak about the factors that you need to put in, so that's perfectly fine, And then in terms of the Blakemore tube, sorry, even before we get to that, as you said, the lab work that you need to do, everything, perfect, absolutely on point. And I hope whoever's watching the video really takes that to heart, because in essence, it's a patient who's bleeding. That's it. There's really nothing else to it. It's a patient that's bleeding. So you want to make sure that they don't have a coagulopathy. You want to make sure, like you say, that they don't have liver disease. And then you want to make sure that you can see, or at least get an idea of where the bleeding may be coming from. And then you want to stop the bleed. I mean, that's it. It sounds simple. And it is supposed to be simple. The problem comes about where the bleed is. You kind of, put your hand down, go and squash it.
And go stop,
Exactly, and as we're saying, tranexamic acid now, especially in GI bleeds, it doesn't really work all that much. It's still got a bit of use for, like gynae bleeds, epistaxis, things like that. Some of the smaller bleeds it tends to help with, but you're right, with upper GI bleeds, it has absolutely, no. And as you're saying, you want to get your GI specialist. Now, that's very good, especially where you're going to be. You're in a large city at the moment, and you're going to be going to the US, where you've got your your specialists available to you 24 hours a day. And then you get those of us who work in situations where you are the specialist, there's nobody available, and you've got to now try and control this patient as well. So I just wanted to add a little bit on about that, especially because, I mean, listen, I'm sure you've been following my lecture. So, I work in a relatively reasonably sized hospital, which is an 800-bed hospital. We're a regional hospital. We serve a population of 4 million, but there's no Blakemore tube in my hospital. None. It doesn't exist. Can you believe it? There's nothing there. All right. Now, the reason I know this is because I've had so many upper GI bleeds over the years. So we actually use a slightly different technique, because the only place that you can get the upper GI, I mean, the Blakemore tube, is if we send them down to another, what we call a tertiary hospital, which is one level above us. They keep them there, which doesn't really help because it's a 3-hour journey. Your patient's going to bleed out.
Exactly. By the time they get there,
it's going to bleed, So we actually have, what you call it, we have a little jury-rigged one, or a little one that we've kind of made up ourselves. So what we do is very similar to the Blakemore tube, in that we take a nasogastric tube and we wrap a condom on it, all right? And up till about the point where you saw the main stem of the Blakemore. Now, we unfortunately can't inflate it in 2 parts because we don't have 2 bulbs. So you're aiming specifically for the esophageal varices. So what happens is that over your nasogastric tube, you actually pull the condom up. We use a rubber band, and we tighten it at about that length, say about 10 centimeters. And then you measure out to where your patient's esophagus is more or less going to end, at the Xiphi-sternum. We pass it through till there. And then we, of course, roll the condom right up to the top of the nasogastric tube. And then we inflate it with air or liquid. And it actually provides quite a bit of pressure as well. The only difference is that we can't pull it back. So when you pull that back, it will just slide out, because there's nothing in the stomach itself. It's just sitting in the esophagus. It's not perfect, but it has worked. And especially for those who may be watching, who are working in rural hospitals, semi-rural hospitals, it is something that you can use. It does work. It does fail. So if it fails, you are in trouble. But, the most important thing is that, as you were saying, you've got to pass as much blood into your patient as possible. And the good part is that the stomach is a relatively contained space. So if you can get your patient on an antiemetic like Maxilon, metoclopramide, whatever you want to call it, and you can get your patient to at least stop bringing up that blood, they can sort of semi-tamponade themselves. And as you're giving blood, otherwise you're giving blood, it's like pouring blood into a bucket with a hole at the bottom. It just keeps on coming out. So, at least by giving them blood, you can keep them alive until you can get them somewhere. And then, of course, it depends on whether you've got endoscopy available or not as well. So, of course, that's the ideal. You do want to get them into an endoscope as quickly as possible. And once you've got endoscopy available. But the question still remains, and you might be faced with this if you end up in the Midwest, in some of the smaller areas of America, where they don't necessarily have, we think of America as having the best health system in the world.
Yes, true. It's not.
They're actually closer to number 30 in the world. So
yeah.
They're very similar to a lot of other countries where if you're in a big center like Los Angeles, New York, Miami, you get the best of treatment as long as you've got the money. But if you're not in those, or if you're faced with, I suppose they don't have a public health system, but they do have free clinics and things like that. The only other options are, of course, to physically open up the patient, especially if you've got a perforated peptic ulcer, if you've got an aortic enteric fistula and things like that. So you have to go in via the abdomen and you have to remove, partial gastrectomies, aortic bypass grafts, as you had mentioned, things like that. So these are the other options that people have been faced with. And I can tell you, having done a partial gastrectomy in my young days when I was still planning to become a surgeon in those, it's not a fun procedure. There's a lot of blood, and it does work, but it's not ideal for the patient as well.
Yeah, for long term, it wouldn't be the best. Yeah.
Exactly. I mean, if you've got somebody who only weighs like about 40 kilograms and you end up taking out half their stomach, they're going to be an unwilling anorexic, unfortunately. Yeah. If you get somebody who's large, why not? You save them a lifetime of dieting. They'll lose a lot of weight, but otherwise. Now tell me, based on where you are at the moment and based on your studies, if a patient had to come in now with hematochezia and a lower GI bleed, what would be your approach to that? Because I'm sure we concentrated a lot on the upper GIs. I just wanted to ask as a question from my side, what would you do for a lower GI who's coming in? Because with hematochezia, they can also pass large amounts of blood as well. What would you recommend?
So I think for lower GI bleed would be a similar approach. Again, I think the first thing would be to transfuse them again. Because they are losing blood at the same place. It's just, it's a lower GI bleed.
Exactly.
That's the only difference. Yes, I think, but I wouldn't go as far as tamponading we wouldn't do that. We'd rather get, I think they'd need a scope, probably sigmoidoscope.
Sigmoidoscopy, colonoscopy, things like that.
Colonoscopy, things like that,
That's for sure. Well, the problem there is that you don't know exactly where the bleed is coming from. It may be coming from the the large intestine, may be coming from the small intestine. You may not be able to tamponade it at all. And, especially with malignancies, it's so common and you never know what you're going to find in that abdomen as well. So I really like the way that you set out the massive transfusion protocol, and it's something I always try to teach people, the 1:1:1 approach, and trying to make sure that you go along that. So this is just, I'm going to give you a bit of a brain teaser now, right? So I'm hoping you can answer this for me. So we've given this patient our blood, we've given them our fluids, we've given them our FFPs and things like that. We're giving them our antibiotics, we're giving them all of that. Do you know of anything else that we could possibly give to try and assist them with clotting? And what electrolyte are we worried about during this massive transfusion thing? I'm sorry, I'm not your examiner. I'm not going to give you points.
No. So the electrolyte we'll be worried about, I think, would be calcium.
Very good. 10 points.
Yeah, would be
excellent.
Yeah, because citrate binds with it, so we would be worried about calcium. Exactly. The heart's not going to work in, because of it.
Exactly.
I don't know what else we could do though.
Yeah.
I would just keep giving blood. But I don't know what else.
That's what most people would do, and in majority of the cases it would work. But that answer is absolutely excellent. Once you start going past your second or third unit of blood, your calcium levels just start dropping into the ground.
Start dropping, true.
Yeah, and people forget about that, and they wonder why the patient is having an arrhythmia, is showing signs of hypocalcemia. In the meantime, they don't realize they're the ones who've been flushing all the calcium out of the, with the citrate over there, So once you're on that massive transfusion protocol journey, the only thing extra that I could add on there, well, there's two things actually. Number one, you're going to think about giving them cryoprecipitate. All right. So cryoprecipitate is basically your it's a highly concentrated form of clotting factors, and it's kept in, the reason it's called cryoprecipitate, I mean, it's kept extremely cold. It's normally kept in a specialized fridge, things like that. So if you have access to it, it's great. It's a 50 ml solution, 60 ml solution. You pump it into your patient, and next thing you know, your patient just stops bleeding. That's it. If you really, you can use it. But I must be honest, it depends on where you're working as well. And if you have access to it. Then the other thing that you can do, it's called, it's on the tip of my tongue now. I was thinking it out, and then it's a rotational fibrin analysis, rotational fibrinogram, something like that, if I remember correctly. But it's something you find in very specialized ICUs, all right? But essentially what they do is they divide all of the clotting factors into different parts. And by a method of, checking the elasticity of the blood, it's a very interesting thing. I'm trying to recall all of it now. I think the last time I'd seen this was maybe a couple of years ago. So you'll forgive me if I can't remember it. Rotational elastogram. Yes, that's what I'm thinking about, rotational elastogram. So when you do a rotational elastogram, it's basically a lab test with a specific specified type of machinery. So what it does is basically breaks down the clotting into different parts, and it tries to test exactly which part is giving you the problem. Why aren't you clotting? And then it tells you exactly what needs to be replaced. So that's something else that you can use, but it's really more in the advanced ICUs that you tend to get that. And failing that, there is one other thing that you can do, and that is ECMO. All right, which is especially if you're going to America, ECMO is like, it's like giving oxygen. They give ECMO to everybody who's in ICU, all right? So for those who are maybe listening to this and are wondering what the hell is ECMO, it's not the name of one of the ghosts on Ghostbusters. It's extracorporeal membrane oxygenation, all right? So basically remove the blood from the body, oxygenate it there, bring it back in. What it does is it gives you a chance actually to have a look as well at how well you are clotting, how well things are going, try and replace blood via that bypass system, things like that. And you can keep a patient going for quite some time on ECMO as well. So you'd often find in the higher ICUs, they tend to use a combination of all of those things. But patients tend to demise quite quickly, and it's not something that in the emergency department especially you'll get a chance to do. So the ECMOs and elastograms and all of that are great for ICUs, but the way you described everything that we do in the emergency department is actually absolutely great. That was actually a very brilliant presentation. I cannot believe that you have just qualified, because you actually know it quite well, So really, you should feel proud of yourself, and they'll be lucky to have you in America, that's for sure. You don't want to come to South Africa and work? No, please don't.
Oh, I would love to.
No, don't come to South Africa and work.
No, I'll quit telling Kimmy that I have to come.
No, but it would be a pleasure if you ever came, really. I'm sure, you can see you really know your stuff, so don't worry. But the other thing I was going to say, and it applies to every part of emergency medicine as well. We try what we can, and our job is to save life, but it's not to prevent death. Some patients are too far gone. There's not much that we can do. They've bled out that much, or they've been injured that badly, or whatever it is. And there's really not much more you can do. So you follow your principles as you've laid them down, which was perfect. It was really step by step. I really enjoy it. And if you do it like that, you'll save 9 out of 10 patients, and you'll do it without any problem. So, you really spoke about it very well, and I hope you'll do another presentation for us on something else very soon, really.
Yes,
Now, the causes that you had mentioned, I was really happy with that. You're 100% right on all of those, so, and especially the alcohol, and I think I'm not sure if we discussed smoking, because smoking is also another common cause of it, I can't remember. I think we skipped through the slide.
It wasn't there.
Oh, okay, no, I mean, tobacco use is also, I mean, it's not generally associated with severe bleeds, but especially if you have a combination of tobacco, alcohol, NSAIDs, all of that. Yeah. In South Africa, we have a drug that's called Grandpa. It's a strange name, but it's one of these NSAIDs that's been around for like years. It's been like since the 1940s, it's been there. And there's a lot of people in our country that just use it, on a daily basis. It's sort of like popping a Disprin. You know, you
Okay,
have
okay.
people all around the world who just pop dispirins everywhere. So we have the grandpa syndrome, where we have patients just popping grandpas every day for their arthritis and headaches and things like that. And when they do come in with upper GI bleeds, it's quite severe, you know, because it tends to excoriate the entire surface of the stomach, you know, as compared to an ulcer, which is quite isolated. Here they tend to have quite a generalized bleed, and those are also quite difficult to stop. And the other thing I just wanted to mention with the Blakemore tube, you know, she had mentioned the passage of the saline. Actually, what I had noticed with the passage of the saline, if your Blakemore ruptures and that water leaks into the stomach, those patients actually bring that all out. So saline sometimes has been touted as not the best thing to put into it, even though it's designed to have saline inside it. So some of the studies have used air, just straight air, because remember, you're just trying to create pressure, and water has the advantage of creating more pressure with a lower volume. So air has to have a slightly larger volume. So, you know, that's one of the other things that can happen, you know. So, but really, Trisha, well done. Well done. I'm quite happy. Like I said, I'm just adding my little bits on at the end as well, but really you spoke about it very well. So what we'll do now is that let me, what you call it, we're going to end the recording now. So I hope everybody learns from this. And then I'll chat with you for a second now as well. Okay. But to everybody else, goodbye.